Hi all, Gavin Greenfield here again. In order to understand why we tend to have tight CO2 brackets in patients with good hemodynamics and wider CO2 brackets in patients with poor hemodynamics, we need to have a good understanding of the VQ ratio. Here we have a lung unit, we've got an alveoli, and we have deoxygenated blood that's coming from the right side of the heart through the pulmonary artery and then eventually into these capillaries that go around the alveoli. And this is a schematic of a single alveoli unit with the alveolus and with the capillary going by it. And that blood gets oxygenated, and that's why it turns red here. And it goes back through the pulmonary venous system and ultimately to the pulmonary vein, and it returns to the left side of the heart as oxygenated blood and then gets pumped out by the left ventricle to feed the body, so to speak. So here we have a single alveoli with the capillary going by it, represented as the V, ventilation, and Q, perfusion. Don't ask me why it's not a VP ratio. Actually, I used to know it's something to do with, there's an answer on the internet anyway. V, ventilation, Q is perfusion. And here I've represented a relatively normal relationship. So this circle is going to represent a normal amount of V, and this shape here is going to represent a normal amount of Q. And here we have that same relationship. So this we're going to call a normal VQ ratio. Now, how can we decrease V? I think we know this. This is one of our 5 causes of hypoxemia. We can have things like pus, blood, or fluid on the inside of these alveoli, or we can have atelectasis that's sort of compressing the alveoli from the outside. And that's going to, all those things are going to result in decreased V. And schematically, it's going to look like this. So now, compared to this image on the left, where we've got this normal relationship, we have the same Q, but much less V. This whole discussion does not include the contribution of hypoxic vasoconstriction. We're just speaking conceptually here. So we've got a small v and a relatively large Q, as I've sort of drawn out over here. So this is a decreased VQ ratio. Okay, the V has decreased because, again, of pus, blood, or fluid, or potentially atelectasis. So what does that do? That is a trend towards shunt physiology, and that causes hypoxemia. This is one of our 5 causes of hypoxemia. When we're talking about CO2, we're speaking about dead space. And what dead space ventilation is where we have a high VQ ratio. So here we have our normal V, but you can see the Q is much smaller than the image above. And so when do we see things like that? Well, the most common thing is probably shock. PE is also a common thing. So if you've got shock, especially if you've got hypovolemic or obstructive or cardiogenic shock, you're going to generally have decreased cardiac output. Now, we typically think of cardiac output as coming from the left side of the heart, but it's the right side of the heart as well. And when we have decreased right ventricular output, we have decreased blood flow going out into the pulmonary artery and ultimately decreased blood flow going through these capillaries that run by the alveoli. So that's how shock causes it. PE causes the same thing, but on a more of a regional basis. You know, you'll have this big clot, and you could imagine that there's not much Q or blood flow going beyond that clot. So in both cases, we have this scenario where we still have V, but we've got a small Q. So we have this big V, but this small Q. This is a trend toward dead space ventilation. So an increased VQ ratio is a trend toward dead space, and this results in decreased end-tidal CO2. The reason for that is, remember that the amount of CO2 in the atmosphere is essentially 0. It's very close to 0, and from a math perspective, we can consider it as 0. So when we breathe in, we're breathing in 0 CO2. So if we imagine this unit right here, well, let's go back to this unit. If we imagine this unit here, we have 0 CO2 when we breathe in. What happens is the CO2 comes through the Q and diffuses here and then gets breathed out up here. And our end-tidal CO2 detector, which is just outside the mouth, reads that CO2. Now, if we have this scenario here, we have a much less Q. So we're still breathing in, so we're going to have 0 CO2 from the atmospheric air or the mechanical ventilator air or the BVM air or whatever we're breathing in. It doesn't have any CO2 unless we're in some kind of rebreathing situation. And so we breathe in 0 CO2, and in this scenario, again, Q is decreased, so there's not as much blood flow to offload CO2 into the alveoli. So we're going to breathe back out, and that end tidal is going to read lower because it's going to be a mixture of the less amount of CO2 that's coming from the Q and the 0 CO2 that we breathed in. Okay, so that is again going to result in a higher VQ ratio represented by this big V relative to the smaller Q, and that's a trend towards dead space, and that results in decreased end tidal CO2. Okay, so you can see why patients with unstable hemodynamics, patients who are in shock, will have a falling end tidal CO2. And of course, the other side of this, the classic description is your cardiac arrest patient. We use end tidal CO2 for two things as a marker of good quality CPR. The higher the end tidal CO2, the more right ventricular output, and that's reflective of better chest compressions. And of course, when we get ROSC, we see that end tidal CO2 typically increase quite markedly. And again, that's because we have better cardiac output. So all we're talking about here is the reverse of that situation. So end tidal CO2, and I've been saying this through the vent courses for 2 or 3 years now, really it's a vital sign and we should look at it. It gives really excellent information on perfusion. So typically, classically, we have 4 vital signs. We've got these 4: heart rate, blood pressure, respiratory rate, temperature. 5th vital sign most people would consider an SpO2. Well, our 6th vital sign is going to be our end tidal CO2. And I think in any patients that are not stable, even if they're not intubated, we've got the non-invasive end tidal CO2 detectors now, and I think we should be employing them more often than we probably do. Here's a couple studies just to kind of emphasize these points. These are both open access articles. The links are here and here. In this sepsis study, the first one there, lower end tidal CO2 levels were the strongest predictor. So what they did is they looked at these 6 vital signs and what best predicted sepsis, severe sepsis, and most importantly, mortality as pre-hospital variables. So they looked at all 6 of these values in the pre-hospital world, and the end tidal CO2, a low end tidal CO2, was the strongest predictor of mortality amongst these 6 vital signs. End tidal CO2 also correlated very strongly with bicarb. So as your end tidal CO2 lowered, so did your bicarb. And it was inversely correlated with your lactate. As your end tidal CO2 lowered, your lactate increased. And I think when we think about this in the context of the VQ ratio and what causes an increased VQ ratio, i.e. shock, that makes a lot of sense. The trauma paper looked at end tidal CO2 in the pre-hospital environment, and it was associated with higher mortality. A low end tidal CO2 was associated with higher mortality. Statistical analysis, and what they did was they looked at the area under the receiver operating curve, suggested that the end tidal CO2 was a better predictor of mortality than both heart rate and the SpO2. And it was at least as good and potentially better, didn't quite meet statistical significance, than blood pressure. So hypotension and a low end tidal CO2 is at least as good as predicting mortality as hypotension. So again, I think this is again reflected in the previous slide as to why that is, and hopefully you're convinced now of the value of monitoring end tidal CO2 in many of our patients. And I'll leave it at that. Fire any questions my way. Thank you.